Welcome. Good morning. Welcome to the webinar, Indigenous Aging Research, Current State of the Science and Future Directions for Research, developed by the Gerontological Society of America, Indigenous Peoples and Aging Interest Group, and supported by the Mentoring Effect, a special project of the GSA Innovation Fund. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentation. We will be accepting questions through the questions feature accessible on the right-hand side of your screen. Next slide. My name is Jordan Lewis, moderator for today's program, along with Sarah Yonke, Frisch Institute for Senior Care's Scholar in Residence at Florida State University at Jacksonville. We are pleased to be part of this important program. Next slide. Before we begin the program, we would like to know a little bit about who is in the audience. Please take a moment to answer the poll that appears on your screen. We'll keep this poll open for about a minute to allow everyone time to answer. Okay, looks like half of you are with the government and half are affiliated with other, so we appreciate you being here this morning. Without further delay, I'll hand the microphone to Sarah.
Thank you so much for introducing me, Dr. Lewis. I appreciate it. The title of my presentation is on Indigenous Aging Research, Current State of the Science and Future Direction for Research. And as Dr. Lewis said, I am the Scholar in Residence at Florida State College at Jacksonville's Frisch Institute for Senior Care, which was recently established from a foundation grant we received. And we'll go to the next slide. So this is just a general outline of the presentation today. We're going to talk about demographics and epidemiology of Indigenous elder research, past research that was conducted within the past around 15 years, since 2000, and also current research, what's being done today. And we're also going to discuss some of the Native Elder Research Centers that are currently present in the nation. Methodologies used. There's certain methodologies that have been used with Native elders and their families that have worked well with our population. And also I will state recommendations for future research, kind of where the science is heading, and tips on what we can use to improve the interventions that are being developed and for Native elder research. And then we'll have a conclusion from this presentation. And we'll go to the next slide. So just a little bit about myself. My father is a Native American, and he's from South America. We are from the Aymara tribe, which we live in the highlands of Peru and Bolivia and also in Chile. And I have some pictures here. My grandmother, she was 90, I think 93 in the picture of her and my dad in the top left corner of the slide. And then we have a picture below that of our family, and we have a lot of cousins and brothers and sisters. She had 12 children, but only 9 survived to adulthood. And then there's an old black and white picture of my family when my grandma was younger. She was around, I think, 45 in that picture. It was taken back in the 60s. And then I have a picture here of her, and that was in 2008. And she couldn't speak Spanish. She spoke her native language, and she did not go to school. She ended up living actually to 100 years old and lived off the land, didn't earn money, never had health insurance, and also never went to a traditional Western doctor. She received her health care from medicine men and women in our village. So she has inspired me to do the work I do in working with seniors and Native elders and their families. Okay, next slide. So I just want to kind of touch on the demographics and epidemiology of Indigenous elders. In 2014, there was a published report from the Administration on Aging, and there were approximately 231,000 Native elders who were currently enrolled in a federally recognized tribe, which is around a little less than 1% of our older adult population. And then the Native elder population we see is going to expect to triple, especially with centenarians. And so from 231,000 approximately to over 630,000 by the year 2060. And most of our elders we see living in 6 states: Oklahoma, Arizona, California, New Mexico, North Carolina, and Texas. And then 2 frequent chronic diseases that are affecting Native elders we see are arthritis, heart disease, and I'll also add diabetes and hypertension. Most older adults have at least one chronic disease, and many have multiple chronic conditions. And the report actually was in 2011 to 2013, around 57% were diagnosed with arthritis, and 25% reported being diagnosed with some type of heart disease. So this is very significant in the population. And we'll go to the next slide. So I wanted to touch on the Indian Relocation Act because there was a U.S. Census report that says most of our Native population live in urban areas, and one of the reasons for this is the Indian Relocation Act, which was implemented in 1965, and it was a United States law that was intended to encourage Native people in the U.S. to leave their Native reservations and acquire vocational skills and also assimilate into the general population. And this was played a significant role in the lives of Native people moving from the reservation to urban areas. So thus we see around 78% of Native people living off of living in urban areas rather than tribal reservations. And particularly there's cities like Seattle, Portland, San Francisco, cities in Oklahoma and also in South Dakota that were cities where people relocated. You'll see high levels of Native people living in those areas. Next slide. So after I did my review of the literature, I came across a number of Indigenous aging researchers, and these are just a few. I have here Dr. Turner Goins, Dr. Margaret Moss, Dr. Lewis, who introduced me, and who also did webinar 2, a previous webinar back in the summer. Doctors Manson and Buchwald, and they had the NERC, the Native Elder Research Center, which is out of the University of Washington and the University of Colorado at Denver. And also Dr. Lori Jervis, she's done a lot of research in dementia care, as well as Dr. Neil Henderson. Doctors Mary Kepa and Lorna Dial, they are Indigenous Maori elder researchers, and they were part of a study called LILACS, and we'll discuss that in the presentation. And also Dr. Paula Carter, who is out of the University of North Dakota, and she also runs a Native Elder Center, and I have a link to that center, and they have really good education material and focused on Indigenous elders, so I think that will be good for people to take a look at. Next slide. Okay, so I'm going to start with Dr. Margaret Moss's research. And Dr. Margaret Moss is a PhD prepared nurse. She's also an attorney, and she did a study back when she was at the University of Texas Health Science Center in early 2000, and she actually received NIA support for her research, and it focused on Zuni elders, and she used an ethnographic approach to examine the chronic disease and health experience of these elders. And from her work, she conceptualized a phenomenon called tolerated illness, which is basically a discordance between the subjective and objective health of a chronically ill patient. In this case, she looked at Zuni elders. And so she looked at approximately 600 elders over the age of 60 on the reservation, and from these, from their interview, she constructed the theory of tolerated illness. And this means that the elder, for example, may rate their health significantly better than a provider would. So it's important that providers ask additional questions regarding elder health, such as functional and physical abilities, and also obtain an more accurate picture of wellness for the elder. This could have profound effects on research interventions with Native elders. Just directing questions toward the elder, gathering as much data as you can when doing health assessments is very important. The elder could say that they're in good health due to their socioeconomic status or health-seeking behaviors, or even cultural barriers, or and they may really view themselves as being in good health. However, the provider may do an assessment on them and their health might not be in the best shape. So it's important to recognize this and assess as accordingly. Dr. Moss states that interventions for care based on her theory will lead to better health outcomes for elders in dealing with chronic disease and tolerating illnesses. And so that's her research. And she also just published a book on healthcare and nursing, and I think that will be out in December. So we'll go to the next slide. And Dr. Lori Jervis's research is focused on Native elders, dementia, and also caregiving, family caregivers. And Dr. Jervis also received support from the National Institute on Aging through KO1 mechanism. And she used a mixed method study to interview approximately 150 Native elders at a senior nutrition program in the Northern Plains area of the country. And she published around, I think, 3 papers from her study and more, but there's 3 that stood out. The first being that she was looking at using the MMSC, which is the mini mental state exam, which assess memory and cognition, and also the dementia rating scale. And she used these scales to evaluate dementia cognition in Native elders. And she found that, she used multivariate regression and identified a younger age, more education, and not receiving supplemental Social Security income and frequent receipt of healthcare needs as a predictor of better performance on the mini mental state exam for these elders. She also found better performance on the dementia rating scale was predicted by more education, boarding school attendance, and not receiving supplemental security income, and frequent receipt of needed health care. And so this study points to the importance of economic and educational factors on cognitive test performance among Native elders. She also looked at psychiatric and behavioral morbidity in Native elders residing in nursing homes, and she found that there's high prevalence rates of non-Alzheimer's cognitive impairment, anxiety, and resistance to care, which were met with psychopharmacotherapy medication, reorientation, and informal techniques for behavioral management. She also found significant depressive, anxious, psychotic, and behavioral symptoms that remained amongst residents. And staff interpretations of resident problems consisted of an ethno-psychological schema emphasizing resident loneliness, grumpiness, and propensity to fight rather than formal psychiatric nosology. And then she also looked at the negative and positive aspects of elder care. And for her study, she used the positive aspects of elder care, I'm just trying to find it here, positive aspects of caregiving, and evaluated caregivers taking care of Native elders with dementia. And she found that caregiving manifested as part of a complex exchange of assistance rather than a unidirectional provision of assistance from family members of the elders. She also found that caregiving emerged such an overwhelmingly positive experience in communities faced with poverty, alcohol disorders, trauma, and cultural traumatization, all of which is a testimony to the importance of the role of the elder in the family, which continues to play in the community. We'll go to the next slide. Okay, Dr. Neil Henderson, who is from the Oklahoma Choctaw tribe, also did research with Alzheimer's disease and Native elders, and he examined the cultural construction of Alzheimer's disease amongst Choctaw elders and their family caregivers. And for his research, he used a cultural construction of disease to analyze an unusual case of dementia amongst an American Indian family. Dementia was predicted to increase in American Indians due to increases in longevity, and then that results in people living longer, so then they're at risk for getting dementia diseases such as Alzheimer's disease and vascular dementias. And he also found that the dynamics of longevity is consequent increased the risk of dementia, and the construction of meaning for dementia was postulated as a natural laboratory for observing the process of meaning evolution for dysfunctions producing perceptible symptoms, particularly ones that involve cognitive and behavioral issues. Dementias are medically considered pathological, but in popular folk terms, often considered a normal outcome of aging in this population. In this case, however, a non-pathological etiological attribution is found and designated as supernormal because symptoms are interpreted as normal, but especially since the symptoms represent communications with the supernatural world. And we'll go on to the next slide. And Dr. Goins, who's part of the faculty at West Virginia University, she used a cross-sectional study design to study disability in Native elders 65 and older. And her study showed that Native elders experience high rates of chronic disease. And she found that 2/3 of the sample experienced some degree of comorbidity according to the scales used, and older age, poor physical functioning, depression, and lower personal mastery were all correlates of higher comorbidity scores among this population. And she also found that older American Indians experience higher rates of hypertension, diabetes, back pain, and vision loss as compared to the national statistics for older adults. And 2/3 of her sample experienced some degree of comorbidity according to the scales used in her study. Older age, again, poor functioning, depression, also were correlates of higher comorbidity scores. And so despite medical advances increasing life expectancy, morbidity and mortality statistics suggest that the health of Native elders lags behind the majority of the population. So these findings highlight the importance of supporting chronic care and management services amongst Native elders. And we'll go to the next slide. Okay, we have here a RICMAR, which is a center supported by the National Institute of Aging. And I mentioned this earlier, Dr. Spiro Manson and Drs. Deidre Buchwald, they run the center, and they are from the University of Colorado at Denver and University of Washington. And this center was established in 1997 to address health disparities experienced by Native elders and to increase the participation of Native people in research. And some of the studies I just talked about, I think, came from, were supported by the RICMAR, and so they're doing great work for Native people. And we'll go to the next slide. And I also wanted to acknowledge the University of North Dakota's Aging Center. And I put a link here that takes you to the website. And also there's a link at the end of this presentation. I have a resources slide that has links to the RICMAR and also other resources that I think are worth looking at. So Dr. Paula Carter, who's an enrolled member of the Turtle Mountain Band of Chippewa Natives, is the director of the National Resource Center on Native American Aging at UND, and she's also an assistant professor with the School of Medicine and Health Sciences Center for Rural Health. So their center has really good information on education, community-based research with Native elders, and I think it's worth looking at. They take a lot of the studies and create educational programs for elders, so it's well worth looking at. Next slide. Okay, the LILACS New Zealand study was a study that involved Maori and non-Maori researchers at the University of Auckland. And this was started in 2010 by their School of Population Health. And so the aim of the LILACS study was to describe the health, social, and cultural environment status of both Maori and non-Maori in advanced age. And they wanted to identify health, social, cultural, and environmental predictors of successful aging by looking at one's quality of life, health-related quality of life, functional dependence, and maintenance of health and longevity. And so this was a collaboration that was set up jointly between the leadership of both Maori and non-Maori investigators, and was a collaborative between the University of Auckland and the University of Otago and also Massey University. And so the criteria for being in this study included Maori who were in 2010 between the ages of 80 and 90 years old, and so they were born between January 1st, 1920 and December 31st, 1930. And also non-Maori people who were aged 85 years and older, so born between January 1st, 1931 to January 1st to December 31st, 1925. So sorry, it's just non-Maoris who were 85 years at the time. And also geographical boundaries of district health boards on the Bay of Plenty and northern part of the lakes area were chosen as a stable population base in an area of Maori communities. So the methodology used for this study was informed by Kaupapa Maori and was utilized during the study to have oversight of the study and how it went. So these group of Maori elders were responsible for translating the questions and ensure that the practices of the researchers that they engaged with and interviewed Maori participants and that their interviews were appropriate. And currently they're in their 6th year of operation of this study. Next slide. Okay, and Dr. Jordan Lewis, who introduced me at the beginning, he is an Aleut native aging researcher from the native village of Naknek. And his research is focused on successful aging and also healthy aging that encompasses family and community engagement, spirituality, and a sense of optimism and humor that Native elders use to promote health. He's also looking at rural versus urban definitions of aging, differed by levels of optimism and hope for future. And his future work for his research focuses on incorporating cultural values and context into the aging process, family dynamics, and elder-centric interventions. His current research also focuses on peer-based alcohol interventions, cultural understanding of Alzheimer's disease and dementia, and an urban-based Alaskan Native aging. Okay, we'll go on to the next slide. And most recently, Dr. Sarah Flicker and her colleagues published a study entitled Research Done in a Good Way, the Importance of Indigenous Elder Involvement in HIV Community-Based Research. And Dr. Flicker and her colleagues presented the data from a larger qualitative study exploring ethical issues that occur in HIV-related CBPR research through experiences of researchers engaged in CBPR. And this study took place between May 2010 and July 2011, and they interviewed around 51 academics and also community research team leaders and federally funded CBPR studies. And they used thematic analysis to identify themes. Participating researchers engaged elders, Native elders, in the research because they felt the elders are keepers of Indigenous knowledge. They are dynamic ethical consultants. They are also community protectors and a credible source of information. And they are able to counsel, support, mediate conflict, provide local context and history, and conduct ceremonial roles. Potential challenges they found cited by participants in this study were engaging elders in research included finding the right fit, approaching elders in a culturally appropriate way, and also bureaucratic environments that do not honor Indigenous processes. So I thought this was a well worthwhile study to look at because they considered Native elders as a guide in the research process, and then also challenges they face in doing this. And we'll go on to the next slide. So I just kind of wanted to talk briefly about my study. I looked at chronic disease in Indigenous elders in an urban setting in the Pacific Northwest. And this study was brought to me by a community center that I partnered with. I originally went to the community center and was providing health screenings and assessments for elders. and also bringing students with me to expose them to diverse groups of elders. And I use a CBPR approach, community-based participatory research approach, and use a descriptive qualitative methodology to look at 12 elders and how they viewed chronic disease, what Western practices they use to deal with their chronic disease, and also Indigenous healing practices that help them with maintaining their health. And I also talked to 2 key informants and also some family caregivers. And so this study was funded by a postdoc fellowship I received through the University of Utah under a T32 grant. And I'm in the process of analyzing the data. But it was a very well worthwhile study. I enjoyed getting to know the community, and I hope to publish this research in the next year. So please look out for that. And we'll go on to the next slide. So you probably heard me mentioning the term CBPR and many times in this presentation, and I wanted to touch base on that because this has significant impact with doing research with our Native elders. So CBPR has its roots in social and political movements in the 1940s, and then it saw a revitalization in the 60s and 70s. And in 1940, Kurt Lewin began talking about action research as a means to overcoming social inequalities. He also rejected the notion that in order for researchers to be objective, they need to remove themselves from the community of interest. And then later writings by the educator Paulo Freire in the 70s brought to the forefront the issues of having communities identify their own problems and also their solutions to these problems. So CBPR is a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each person brings. So basically both the researcher's strengths and the community they're researching. CBPR begins with the research topic of importance to the community that's being researched and has an aim of combining knowledge with action and achieving social change. Before such conversations, however, can occur, it's necessary that researchers spend time establishing trust in a community. This can be done by consulting with Native communities and engaging them in the research process from the very beginning. Usually key informants, elders, community leaders, etc., are involved and have valuable knowledge about the community they live in and which they serve. So given the diversity of potential collaborators, researchers must be careful to not favor certain types of associations that are based on predetermined notions of what constitutes as an appropriate collaborator. So for example, going to a community, you would see an elder, for example, even though they might not have higher education or formal education, but they're very knowledgeable at the community. That's very important that they're included in the research process if they want to be included, and also if they have the knowledge about the community that you're thinking of doing research with. And then it also acknowledges that the community and the people that are being researched are experts on their own life circumstances, and that participants are ideally situated to suggest the most appropriate collaborator to meet their needs. So we'll go on to the next slide. I also want to touch base on the context of colonization. It's important to address this because this has affected lives of Native people across the Americas. And so before proceeding with research, it's important that researchers take into account the concept of colonization, the history of Native peoples, including elders. For example, what constitutes as good health for an elder might not constitute as good health for someone else coming in looking at this person. So transforming research processes and health interventions to include Indigenous knowledge is important. It breaks down notions of colonization and empowers the people we're studying. And it also has a large impact on the health of Native people. I also want to mention from Dr. Moss's study, creating, this is just an example, she gives communicating with the creator or metaphysical dimensions of spiritual world can signify health and well-being because you're in touch with spirituality, with your culture. In many Native tribes, conversely though, the context of the dominant culture, such as who might look at these events as maybe the person having a psychopathology, they might be hearing voices, talking to oneself, but they're really not. They're praying. They are in touch with their spiritual self. So it's important to understand this, and that, again, using the theory of a CBPR, the philosophy of CBPR, will help researchers understand this context and also breaking down barriers of colonization and hopefully having positive health outcomes on the community. We'll go on to the next slide. And so I wanted to also address meaningful research. So meaningful research should include Native and Indigenous knowledge of wellness that emphasizes harmony between spirit, the mind, body, and the context or environment, rather than competitions between these concepts. So with these knowledges, the relationship between Indigenous people and aging is harmonious, that we can't have good physical health unless we also have good mental health and also spiritual health, and we're in a safe environment, for example. So in order for researchers in Native communities to be effective, they must use culturally competent and sensitive care and also traditional values, and taking into account definitions and expectations of behaviors within the community and a myriad of factors that affect communities. We'll go on to the next slide. So recommendations for future research, definitely looking at chronic disease and how it affects Indigenous elders, using Indigenous theories and conceptual frameworks in research studies. And I have here just two examples. There's other theories and conceptual frameworks out there. One is a relational worldview model by Mr. Terry Cross, and that was published in 1997. And also the theory of tolerated illness are just two that I have up here, and that's by Dr. Margaret Moss, published in 2005. And we'll go on to the next slide. And here I have the medicine wheel, and this is it's represented by looking at one spiritual aspect of their life, mental health aspect of their life, physical and emotional. But it's seen as being together in a circle, being harmonious, and that when we take health into account, we must look at the whole person and look at the whole entity rather than specific parts. And so this kind of provides that conceptual model, I think, for researchers to just consider when they're doing research with Native elders. And then we'll go on to the next slide. And that concludes the presentation. I think after this slide, we have our resources slide, and I wanted to open up the discussion or the presentation for any questions people have.
Great, thank you, Sarah, for your very informative and engaging presentation. There's definitely some wonderful and amazing work happening with our Indigenous elders, and it's exciting to see the research grow and more people engaging in this important work. On behalf of the Gerontological Society of America and the Indigenous Peoples and Aging Interest Group, Sarah and I thank you very much for your participation today. Thank you to the Mentoring Effect, the special project of the GSA Innovation Fund, for providing the support for this program. And just a reminder that we are recording this session, and we will send you an access link by email once the recording is available. You will also be able to download a copy of the presentation slides from the website listed at the bottom of the screen. Before we move to the question and answer portion of this program, please know a webinar survey will automatically launch after the webinar. In an effort for continual improvement, we would like to hear your thoughts. Please provide feedback by clicking the survey link at the end of the webinar.
And Jordan, I just wanted to mention that at GSA's, at our conference, we do have a special interest group meeting with Indigenous aging researchers, and we wanted to invite people who are interested. It will be on a Friday, November 20th, and we would like people to come join us if they choose to.
Definitely, thank you for the reminder. And we would love to see everyone there. Now moving along to our question and answer session. Just a reminder that you can type and send questions using the questions feature in the dashboard accessible on the right-hand side of your screen. We will not be using the raised hand feature today, so if you have a question, please be sure to use the questions panel. Sarah and I will do our best to address as many questions as possible, time permitting, during the last part of the webinar. So we have one question. Sarah, can you speak a little bit about how Western doctors perhaps medicalize aging and the effects of aging versus Indigenous aging views of normal aging, and what are the gaps?
That's a great question. I think a lot of times we see aging physiologically. I think we see, skin changes, issues, eye problems, and it's viewed differently because it's viewed as our body deteriorates, that, telomeres get shorter, life expectancy, we have more chronic diseases. But, for example, with my grandmother, we did not see that as that way. We saw her as gaining wisdom, that she had a lot to give despite her many ailments. And my experience working with Indigenous elders in the Northwest, and also doing this review of the literature, synthesis of these Native elder research studies, I find the same thing, that although Native elders have high rates of chronic disease, diabetes, heart disease, arthritis, and that's very apparent in the literature, when you talk to them, they might say, yes, I have those conditions, but I also have a great family, or, in spite of the historical trauma that we've been through, we're still here, and we're still active in our community, active in getting our young people, mentoring them, being role models for them. So it's not just the physical aging, it's also emotional, spiritual, what's happening in the community, and that's health to them. They might, not have the best, blood pressure readings, or they might need a cane to walk, but hey, at least they can walk, they can do things. And so I think it's looking at the positive aspects of what we can do, rather than, okay, well, you have this disease, you have this disease, and this disease, and here's some medication, and that's it. It's more of, let's work as a partnership with everyone, with families, social workers, nurses, physicians positions everyone to help this person be whole, so that when I show the medicine wheel, that their spiritual aspect of their health, the emotional, physical, are all entwined with each other, and that it's balanced, even though they might have a lot of chronic diseases. They're still there, they're whole person.
Thank you. Definitely. Another question is, you discussed earlier in the presentation and throughout in our previous webinar, also touched on this a little bit, but community-based participatory research. Can you discuss any other research methods or approaches to research that are appropriate when working with Indigenous older adults that have been proved productive or successful?
Yes, I can. CBPR is more of a philosophy than a methodology, but I put it as a methodology because some research studies out there, it's under methods, under research methods when they publish papers. And so using that in conjunction with whether you're using a qualitative framework or quantitative or mixed methods is important. What I've seen in the literature is doing both. A mixed methods approach has served well for researchers because you're using scales which are reliable and valid. Most scales may be reliable and valid depending on what you choose, but you're also backing that data up with what the participants say. And so having that qualitative piece and mixing it with the quantitative piece has been successful in many studies, in addition to using a CBPR approach. But that can take a lot of time. CBPR does take time. I know some disciplines, CBPR was not, when it was first introduced, a lot of researchers did not jump kind of on board with it because it does take time. The trust issue with communities, which is understandable. It takes time to get to know someone, to figure out the aims, what you want out of the study, and you have to just be patient and be part of the community. I think just showing up is a big factor, and just listening to what their needs are. And it might not be what we see as important, but if they say something different, then that's important to them, and that needs to be honored. So to answer your question, using a CBPR approach with a mixed methodology, mixed methods approach is what I've seen in the literature as being successful.
Great, thank you. So our last question, unless anyone else has any others, or these questions have spurred some more questions out there, please let us know. But another question is, how can allies or other American Indians and Alaska Natives who want to work with tribal communities that may be their own or might not be their own communities, how can you engage or get involved in this type of research in a respectful way?
That's an excellent question. Being part of an advisory board, if there's already an advisory board formed, going to powwows, asking people in the community, introducing yourselves. Part of it is reciprocity also. For example, when I went and to the partner I made in the Northwest was a Native Urban Community Center, and they had a senior center there. And since my background is gerontological nursing, I went there wanting to volunteer and doing health assessments like blood pressure screenings, glucose checks, and like depression screenings for the elders. And so we offered that, and then they noticed that I came every other week, and then that sometimes they had questions, so we had educational kind of roundtable discussions, and they saw that, okay, well, we can use her as a resource, and then they approached me with trying to implement the CDSMP, the Chronic Disease Self-Management Program, with the elders there at the community center. However, it was unfortunately not well received, and so we were looking at tailoring it, hence my study, which came out of that. But just being engaged, being part of the community is the most important. And even if, let's say, you go to the community center or wherever you decide to go to, come back. Always, part of it is just, I always say 50% of the work is showing up. And if you can do that and just engage with people and talk to them and listen, that's what it's about. And then you'll see the issues come up that they might need help with.
Great, thank you, excellent.
Thank you.
So I think that's the end of our questions. I want to thank everyone for their participation and listening to our presentation and sharing about this important work. I want to thank everyone again for participating, and this is the end of our program.